is a sacral issue or an innominate issue? That's what we're going to kind of dive into and then some treatments. So let's talk about the anatomy. And we're going to start with the innominate. I know people don't actually hear the word innominate enough. If I say innominate, who's going to throw their hands up and say, I say that word consistently? Not a lot of you. Everybody says sacroiliac, but they don't say innominate. So let's talk about what the innominate is. It is the bony structures that encompass the ilium, the ischium, and the pubis. All of that is what I am talking about the innominate. And we will hear it consistently. Because what I want to know in the SI, is it a sacral issue or is it a innominate issue? Because those are two different things and you're going to treat those completely different. So remember that innominate is your ilium, ischium, and pubis. So, starting with that bony anatomy, again, get your iliac crest. These are things that I want you to be very familiar with palpating. Then from there, we go to the ASIS. Very easy to find, making sure that you can really palpate. These are important. PSIS, you will see that a lot today, as well as the ischial tuberosity. Now let's talk about the sacrum. A little bit different and a little bit harder to palpate. So, with the sacrum, one of the biggest things I always talk about is the sacral sulci, as well as the ILA, which is your inferior lateral ankles. Who remembers, if you've heard my talk before, that the sacrum has multiple axes? You remember that? How many? No? 5 axes. Your sacrum rotates on 5 different axes. That's a lot. So we always think this, forward flexion and, again, extension. That's not all. So 5 axes that it actually goes through. So I want you to look at this slide. So I want you to look at where the relationship is the sacral sulci. It is in purple. Because what you want to do is reference the PSIS. You want to go slightly anterior and you want to go medially. Then you'll hit that sacral sulci. That is that promontory base, and you can feel the base of the sacrum. So from that PSIS, you're going to go anterior slightly and medial, and you'll drop right into that sacrum. Finding the ILA, you're going to go walking all the way down the sacrum, and it is the last bony sections before you fall off. Okay? Now remember, with the sacrum and with everything that we do, you've got to make sure that you have a chaperone with you. So make sure that there's somebody else standing there that you can do that because you're walking down someone's rear end. Okay? But that ILA is also important because you're going to see that rotation along with it. That helps you diagnose. So again, where those areas are in the sacrum, look at this. This will all be available to you. So remembering those axes, this is really important because what they're talking about, the 5 axes that I was talking about is both your oblique axis that you can rotate against. So as that triangle, right, it can rotate along those axes, again in flexion or extension. So again, if it's on the left or right, as well as you have the 3 other axes on it. Now interesting, the correlation is important here because you've got that superior transverse axis, and along with that, if you didn't hide it from me though, here's hid it from everybody. There he goes. It's also part of the respiration. So when you are palpating somebody on their sacrum and you're having them breathe and you can feel that motion, it is going on that superior transverse axis. Also, remember that clinical note that I'll add some pearls towards the end, and I'll have to throw those in for you. This one also is part of that cranial sacral motion. It goes against that superior transverse axis. Now your middle transverse axis is your postural motion. So when somebody is standing, it is moving along that axis. And then you have the inferior transverse axis, which is again the innominate rotation. So interesting, right? One sacrum has 5 different axes they can move along. So think about this and what you're doing. So let's go straight into diagnosis. I know I've done this 1,000 times. Utilize your dominant eye in your training rooms, yes or no? Or do y'all forget because y'all get right into being busy and crazy? Tons of athletes walking in. Raise your hand. You're going to have to talk to me. I'm usually doing one-on-ones here. So yes or no? Nope. Guys, this is important, especially. Go find a circle. I don't care. Put The word D in it, I don't care which one. Make sure that both eyes are going through it. Eye that was open and it stays in the triangle is your dominant eye. So here's the problem. Did you see how far it moved out of your triangle? That's a big deal. Now, if you are not on that dominant side, especially for this palpation when we're talking about innominate and sacrum, you will be off. It is going to throw off your diagnosis. Just look, again, do it again if you have to. How far off did that space, whatever you put in the middle of your triangle, fly off? That's a lot, right? So make sure that your dominant eye is consistently over your patient. So again, you can't be dead center with them, but you've got to make sure that you're dead over with your dominant eye. So all of my tables, and I'm just used to setting up patients with my left eye. I'm left eye dominant. I always have my patient where I have my left eye over it. Once you've done this 1,000 times, it will just be automatic for you. Set up your training rooms, that, again, for those tables, that it only goes to your left eye or your right eye, depending on what you do. Okay, so super important, especially for these palpations that we're about to do. So let's move right into the diagnosis. I want you, by the time you leave here, that when you go home practicing this, you'll know exactly if that athlete has a sacral issue or an innominate issue. Because everybody loves to say SI, but really that's two different things that we're dealing with. And how does the low back affect that SI? So let's start with this. This is the one test you'll know exactly, are you dealing with a sacral issue? Or are you dealing with an innominate issue? So we're going to start with motion testing. Okay? I'm going to demonstrate all this here in a little bit. I'm just going to go over the wording at the moment. First is the standing flexion test. One of the biggest things you need to make sure of is that your athlete will be standing right in front of you, shoulder width apart, making sure their feet are planted on the ground, but you need to be at eye level with their PSIS. If you're standing up, you're not going to be able to see that PSIS. You need, as my handy chair is here, because I asked for it, I am eye level as much as I can with the PSIS. Okay. Now, in making sure with this, you're going to palpate that PSIS. This is where sometimes people get a little bit off. When you palpate that PSIS, you want to make sure that you are hooking your fingers right underneath the PSIS and almost superiorly. So you're hooked right underneath. Because if you're right on top of the PSIS, when they start doing a forward flexion, you're going to slide off. Okay? I'll repeat all of this once I have the practice session with this. So make sure you hook underneath so that you can follow with the PSIS. And then again, you're going to have that athlete bend forward, ask them to touch their toes. Please stop right then and there and assess 3 other things. One, again, y'all are going to roll your eyes because I say it all the time, flexibility. How bad are their hamstrings? Because is that throwing off part of their innominate or sacral issue? So assess their flexibility when they're going to that forward flexion. As well, do they have any scoliosis? I've been catching a lot lately. I don't know what's going on with 2021, but I've got at least 3 athletes just this past week that I've been diagnosing some scoliosis with. So this is a perfect opportunity to kind of look at that and monitor that. Okay? Now, a positive standing flexion test is the hand or the side that moves more superiorly or keeps going further. So you can say superior, you can say further, doesn't matter. That is your positive side. That is your positive side. If your right hand moves further, that means your right side is the issue. It gives you half the answers right there. Now, is it a innominate issue or a sacral issue? We don't know yet. But we definitely just found out what side we're dealing with. Right or left. Okay? So then we move to, again, we said the positive standing test. Which one goes more superior is your dysfunctional side. Now we go to the seated flexion test. Now with the seated flexion test, you really want to make sure that you have a stool. I have used chairs, things like that, but the stool works the best. Remind them that it's on wheels, it's on wheels, it's on wheels, because when people go forward, stool goes towards you, everybody falls. Just remind them. You want to make sure that the athlete sits on your stool. has both feet planted. Again, that is completely planted. That's why you can't have them on your table, because their feet is not planted. Okay? Even though it's better for your eyes and back, it's not planted. So, as they sit down, we're going to do the same thing. Palpate that PSIS, hook underneath, and then have them just reach their hands towards the center, again, touching their toes. Okay? Now, again, the positive seated flexion test is the one PSIS that travels more superiorly or further than the other one. Okay? So, right now we've just done a standing flexion test. We know which side we're dealing with, but we don't know if it's an innominate issue or a sacral issue. So we do the seated test. Now, if the seated test and both of your thumbs go equally, okay, that means that it is a negative seated flexion test, and you are dealing with an innominate dysfunction only. The innominate is the problem. Why is that? If you forget about this, once you sit them down, right, the innominates are out of the question. You just sat on your ischial tuberosity and took that out of the equation. Make sense? So now that I took that out of the equation, both thumbs are equal. That makes it's negative seated flexion test. It's an innominate issue. Everybody understand that? So a positive seated flexion test means I still have a problem. That hand is continuing to move, correct? And the innominates are out of the equation. So what's the problem? Say it to me. Sacrum, right? So a positive standing flexion test, a positive seated flexion test means you had a sacral issue. Because I just took the innominates out of the equation. If you get nothing out of this talk except for that, that's all I care about. So as long as you can tell me, is it an innominate issue or is it a sacral issue? Okay? These two tests are going to change your whole world. They've done mine. And most of y'all seen me do this 1,000 times. So, let's do the static exam. Now, we start with the supine position. Now, when I do a supine position, you're going to see me every time. You need to reset the pelvis. Once your athletes get on a table, they shift everything, and then they're stuck in this weird position. So you have to reset it to make sure that you are in the right position. So I always do a reset pelvis. So I have them come up, but then I extend their legs. I couldn't find that all the way through, so this is all you get at the moment. So reset the pelvis. Don't forget, or you're going to have like a wrong diagnosis. Then from there, I go straight into my very quick exam. I do the same way every time. I do iliac crest, ASIS, pubic tubercles, medial malleolus. I can do that in about 5 seconds. I do it the same way every single time so I don't miss anything. Then, again, I can do some motion testing. Usually around the ASIS, I'll do some motion testing, see if I can compress the pelvis at all. And I also do a little bit of rocking with the pelvis. That is usually for L5 motion, and is sometimes difficult if they're ticklish and those type of things. But there also is some motion testing you can do as the static. Now I move them over to a prone position. Luckily, I don't have to reset this position. Again, I go right back to that iliac crest, which is great for Sean, who also mentioned the fact that that iliac crest is at the level of L4. We've said that multiple times. You know where you're palpating. Also, the PSIS. I go, remember from that PSIS as my reference point, we go anterior slightly and medial, right, to hit that sacral base. Go from the sacral base, I go all the way down that sacral sulci down to the ILAs. So I can also do my sacral exam right then and there. Then from there, I tell them again, I'm going to go right underneath your rear end, right into the ischial tuberosities. So I've gone from innominate to sacral, all the way down into one fluid motion. Also, I'll go back to the sacrum. I'll do a little bit of a spring test, and I'll also have a little bit of breathing motion to see if it's stuck in extension or flexion. Does that sacrum have some good motion, or does it not? So, cheat sheet, okay? Sometimes you have to write it all down because we're checking out all these different areas, right? It's difficult if you're trying to remember what you remember when they were supine between prone. So was it the right iliac crest was high or the ASIS? This will help you. So everybody gets to do finger motions. This helps you figure out what's going on. So middle fingers come in. This is your pubic symphysis, okay? Index fingers pointing like a gun. Those are your ASIS. My thumbs here, I usually go right into that as your iliac crest, okay? And then, I'll go this way, I guess, because that's the video. I usually point my fingers towards me a little bit. It's a little bit more difficult, so sometimes I'll hold them in to make it easier. But can y'all see the fact that I can kind of put them towards me? My ring finger and pinky. I do that for ischial tuberosities. So it's kind of hard to hold, so I kind of hold them to me, but I know those are my ischial tuberosities. Pubic symphysis, ASIS, iliac crest, ischial tuberosities, or your PSIS. You can do either one on your ring finger, okay? So when we talk about everything being elevated on one side, things being rotated, I want you to go back to this, okay? There's going to be a quiz at the end, so we'll kind of practice this. So when we say certain things or certain directions, you'll use this hand motion, okay? It will help. So let's start with that. I gave you a chart here to kind of help with this, and it's a walkthrough chart. This will be saved for y'all. Y'all have it, and y'all can go all the way through it. Biggest thing for this one is this is more talking about innominate. Because of the 5-axis and all the different rotations of the sacrum, if you know it's a sacral issue and what side kind of is getting stuck, we can go with that with muscle energy. But the innominate is a lot more common, you'll see sometimes with this, and things that you can do in your training room. So this chart is mostly for the innominate. And again, what did they do? They went from that standing flexion test, moving down to sacralize on which side it is, and then what we're doing is looking at what your diagnosis is. As we go to the iliac crest, which one is more superior? ASIS, which is superior or inferior? Now remember, your standing flexion test and your seated flexion test told you what side you're dealing with, correct? That's the side you're documenting. So if you have a right-sided issue, is your iliac crest equal or superior or inferior from the other side? ASIS, same thing. Is it equal, superior, or inferior to the other side? Only deal with the side that you have the problem on, or you'll get confused. So this chart goes all the way through it, and we'll go through it as we go through the practicing. This is another chart, very simple as well. I did it one in flow and one in just a compacted flow. It tells you again, with a diagnosis of like an anterior or a posterior rotation, a shear. It tells you what you're looking at with your ASIS, iliac crest, also medial malleoli. Also, they also do an ASIS to umbilicus measurement. Takes too long, it's kind of weird, doesn't really need it, but it's there for you in some of the literature. So, I'm going to get my handy person so we can practice a little bit. Any questions so far? I'll go over it all again. Nope? I haven't lost you yet? Almost? A little bit? Everybody's ready to go home? It's Friday, let's go. Alrighty. So, I will probably, because the camera's that way, I'm going to have you face this way. So, I have my athlete, they come in. Again, they're saying they have low back pain. Sometimes they have pain shooting down to the buttocks. I'm not sure what's going on. If it's an injury, guys, please look at it, because then some of that can help you. Did they fall or slide onto one innominate versus the other? Did they get hit? How did they injure it? Is they more dominant? Are they a kicker on that side? It will kind of help you. So first thing I do the same testing for every single patient as they come in, and even if it's for low back pain, I do the same thing. So, patient comes in, again, almost fell, don't sit right there. Again, it's on wheels,
Can you rotate to the, and have Crystal, yep, just like that, that'd be perfect.
Okay.
A little bit less. Rotate, yeah, right there.
Okay, perfect. So first and foremost, I'm eye level with my patient, making sure that they don't hit their head either, so we'll kind of monitor that. I'm going to sit back a little bit because I don't want you to hit your head. There you go. Perfect. So thumbs, this is the most important thing, guys. You really want to come down, find their PSIS, and you want to hook underneath. Remember, if I come right on top of that PSIS, I'm going to roll off when she goes into flexion. So make sure you palpate and really make sure that you hook underneath. I start all of my exams this way, kind of hold my iliac crest a little bit, and I'm going to have you slowly reach down and touch your toes. So I kind of come up. I will tell you, if you can't see it on here, my right hand is going slightly more superior than my left. Come back up. And I usually do it twice. Once is usually they either go too quickly, there's some tension. So again, one more time. And again, I just double check myself and it is the right side. So it kind of comes up, perfect. I will switch immediately. Tell my patient to take a seat. Remember, this is on wheels, it's on wheels, it's on wheels. Make sure your feet are planted. Why do I say that? Because it's happened to me more than once. Chair comes flying towards me, patient ends up on the ground. Not very good for in my office. So, hook underneath. I want to make sure not on top. You want to make sure you hook right underneath that PSIS. And again, slowly reach down and touch your toes. Perfect. Come back up. So she has a positive standing flexion test on the right. She has a negative seated flexion test. Does she have an innominate issue or a sacral issue? Innominate, right? I took the innominates out of the equation and nothing happened, right? So again, it is an innominate issue. One more time, because I could be wrong. Perfect, come back up. Excellent. Have you come lay down here? I want your head. Why? Because I'm left eye dominant. Head goes this way.
On my back.
On your back, please. So I always do the same way every time, supine. So I always make sure that they're on their back. My left eye is going to be over the patient. Again, she did great. I'm going to have you reset your pelvis. Bottom up, back down, leg straight. Perfect. Again, best rule. Do y'all have ticklish athletes? Of course you do. Why wouldn't you? Because they're in my office as well. If they are too ticklish to palpate them, you know the best trick for this? Have their hands on top of your hands. So do it for me. Put your hands right here. I want you to tell them to palpate themselves. There's no way you can tickle yourself. So again, they have to palpate with you. Then they won't laugh. Just a little fun note. One more time. There's both legs. Bottom up. Back down. Because you moved, I saw you. Sneaky. I saw that. So with this, my left eye is over the patient. Again, lift up a little bit. I'm going to go right down and to the front, just letting you know where I'm going. First thing I do, iliac crest. Let's double check and see which one. Iliac crest look equal. Okay, move straight down. Again, ASIS. Looking through here. Remember, what side are we dealing with? So I only care about the right side compared to the left, right? So don't get hung up on anything else. So again, her right ASIS is more superior than her left. So I'm looking at this. I wish I could see it a little bit. So that's about what I see on her. Okay? Good. Again, if you can, I tell my patients, I'm going to use the palm of my hand. I'm going to go down to your pubic bone. Is that okay? I have my chaperone sitting right here, moving down, double checking that. They're equal on that, and then all the way down to the medial mallet. Medial mal, equal. Good. Come back over, and then we're going to go over to prone. So right now, my iliac crest, like we said, right, we're equal. Where was the right ASIS? Superior, right? So I'm already kind of thinking about this thing. Now remember, you just flipped your patient, right? I do this too, so don't laugh at me that I'm correcting this. Remember, you just flipped left and right. You just flipped him over. When you're doing all these points and trying to keep track of it, again, when she was supine, that was my right side. Now this is left, this is right.
So do you ever switch your head?
Huh?
Do you ever switch your head then?
No, because my left eye has to be on top of the patient. Because again, that would be another way of doing it, but then your dominant eye comes off the table. And then you're not in that section. So again, lift a little bit, start with the iliac crest, get my bearings, start with the iliac crest. I come right across with my thumbs because I'm already palpating L4. I will usually go through my spine exam right here and to see if there's any rotation. I'll drop down to L5, come up, L3, L2, L1. This is just what I do every time. So, I'll let you know where I'm going. That PSIS, get underneath, medially, slightly superior, again, sacral base. Then, I'm going to move down your rear end, just letting you know where I'm going. I palpate all the way down for that ILA until I fall off. This is where I fall off. So I can feel that ILA right through here. Okay? I'm going to go underneath your rear end as well. Ischial tuberosities with this. Ischial tuberosities are pretty equal. Slightly on this part. On her right is inferior. Okay? So, right. Now tell me, can you feel the same thing? You can kind of feel where my, right? My left one's going towards your nose. This one's inferior. Okay? So my ischial tuberosity is inferior. All right, here we go. Let's go through all of it again. Standing flexion test was positive on the right. Seated flexion test was negative. Right? Iliac crests were equal. Right-sided ASIS was superior, right? So again with that, coming through, and then her ischial tuberosity is inferior. So what's her diagnosis? Rotated which way? Posterior, right? Do your fingers. Grab your fingers. Right? We're dealing with the right side. Again, ASIS was, again, superior. Remember I used my little ring finger? Ischial tuberosities. Inferior. You have a posterior rotated innominate. That's how I do it, and that's how quick I do it. Again, don't be afraid to keep going through and go, hey, go step by step. Remember which side you're on, which section you're doing, okay? So that chart below tells you everything with it, okay? So thank you very much. That was perfect. I'll come back again and I'll do some other fun things here in a little bit. Okay. Any questions so far on how to do it? This is where we normally, y'all practice on each other. We get it like really practiced. The key word to this is practice, practice, practice. If you do your back exam with this exam every single time, you won't miss anything. And you'll get so used to palpating this, it goes really quickly. Okay? Questions at all with this? Okay. So what is the cause of that dysfunction? So, with this, let's talk about an anterior rotated innominate. Okay, so this innominate is rotating anteriorly. So right now you should be going through your head and saying ASIS is inferior, ischial tuberosity is going a little bit higher, right? You're kind of already thinking that, superior, yep. But what's the cause? More than likely you have tight quads. Very easy, right? Tight, it's pulling it forward. Visualize it. Posterior innominate. So in a second, we're going to be testing somebody's hamstring flexibility in that section. So a posterior rotated innominate, same thing. It's getting pulled back, right? What's pulling that on that ischial tuberosity? Downwards. What attaches there? Your hamstrings. So they have tight hamstrings. Now, let's talk about the shears. I see shears a lot. I see a lot of shears, especially with, again, tackles. They fall. My sliders, and again, my soccer, who slides in, baseball, softball, a lot of, again, my favorite, I went to medical school in Erie, PA, falling on the ice, in case anybody went on vacation. This is a big one. Usually to fall right on that ischial tuberosity on that section. So that whole innominate gets shoved upwards. So there, you should automatically be thinking, if it was a right-sided superior shear, iliac crest, ASIS, PSIS, ischial tuberosity, medial malleolus, all will be superior on that side of dysfunction. So inferior shear is more of a pull on a leg. I see this usually in football. Very rarely is it dragged from a horse, but when you're talking about rodeo, this is a big one. They get caught in the stirrup and they get pulled. So this can cause an inferior shear. Okay? If you're at one of my playoff games that I would see, those guys would hold on to people's legs and twist and turn and keep holding after the tackle was done. So I'll be looking for this. Next one is, again, your pubic shears. Again, when you're talking about your abdominal muscles, your rectus, Again, how tight those abdominal muscles are that they don't usually stretch. And then with the sacrum, I will tell you most sacral issues, I loved one of Dr. Sean's slides, iliopsoas. Tight hip flexors pull that sacrum forward. So I get a lot of sacral dysfunction happening because of the iliopsoas. Piriformis also being super tight. Remember, your piriformis is very easy, that you can easily test. Crystal, sorry, I didn't want to call her out first. Lay on your back really quickly. So, good, leg straight for me. Remember your piriformis and where it attaches to the sacrum? Remember, your piriformis is your external rotator, correct? So if they had a tight, again, at all piriformis on one side, just having them lay here, you'll start to see that they're hanging out in external rotation on one leg versus the other. But if you can't really see it, what I do is I palpate and come above the ankle joint, relax their legs a little bit, and I test internal rotation, right? Because I want to see the resistance. So if her right side was a little bit more tight, you would only let this much go in and then you would see her left. Does that make sense? So you're testing internal resistance. Good. Yeah, there you go. So, looking at that, making sure your hip flexors are okay. Now treatments. Y'all know this, I've done this 1,000 times. I love muscle energy. Why shock the system when you can use the muscles to do it for you? So find out what the problem is, what's causing that problem, tight hamstrings, quads, they fell, and utilize muscle energy techniques to do that. Okay? Reverse the diagnosis, and you can also utilize that counter strain. I will show you a shear in a second because almost every single one of you, every time I perform it, you'll go show me again. And I'll do that one here in a second. After you do any treatments, you have to recheck the whole system that we just did. Standing flexion test, seated flexion test, supine prone. Make sure you did it right. Make sure they're fine. Or is there some other issue that was going on and hiding? Because when I do a quiz here in a second, you're going to notice that. Okay, so recheck, recheck, recheck. I will tell you, you have to be in the know and make sure that you're consistently doing that, or you're going to forget it. You'll have so many athletes to see, and y'all are so busy, y'all treat it and off you go. Because it's ready for the next one. Don't forget to recheck. It's part of all your treatments. So here's a little extras. You know I always like to throw these in there. You diagnose a sacral issue, you've been treating the sacrum, you're trying to make sure you're doing all the releases, you can't figure out why are they still having this issue. Don't forget about that cranial sacral motion. Go check their cervicals. Check their cranium. See if that is a correlation. That might be the biggest problem, and you're trying to treat the effect and not the cause. Also, making sure that you check L5 for restriction with any sacral function, because again, you're going to get that rotation. So they could be complaining of low back, but that back is rotated because of the sacrum, not because of L5. Okay? Also remember that iliopsoas flexion contracture may also cause issues at L1 and L2. Why? It's for their origin. Right? So you get low back pain upper in the 1-2, not just the sacrum, and what happens? It's all from the front end, and you've been working on the back. So don't forget about those extras. Here we go. So you have a standing flexion test on the left. You can bring out your fingers if you need it. You have a negative seated flexion test. Your problem is what? A sacral or a nominate? Say it loud, go for it. A nominate, right? You can be wrong. The more that you're wrong, it's even better, because you won't get it wrong again. So supine exam, your iliac crest, ASIS, medial malleolus are all superior on the left. Now prone. Your PSIS and ischial tuberosity are all superior on the left. Your diagnosis is what? Upslip, right? Absolutely. Remember, it's your left side, right? There you go. So, left superior shear, upslip, whichever way you want to call it. There you go. Good job. Do the fingers help? They're going to help in a minute, especially the last one. I threw in a curveball in the last one, so get ready for it. Number 2, Standing flexion test is positive on the right. Seated flexion test is positive on the right. Sacral or innominate? Say it loud, go. Sacrum, there you go. So my supine exam. Dr. Stevens, why are you even doing a supine exam of the innominate if you know it's a sacral issue already? Because I always do my exams the exact same way, right? Because I cannot come off of my course or I'll miss something. So I know what it is, but I'm still going to do it because there might be some other issues. Iliac crest, ASIS, medial mal are all equal. Prone, PSIS, ischial tuberosities are equal. I have a negative spring test. Again, with this, again, it springs nicely, it's breathing nicely, all looks good. So then I notice when I palpate the sacrum, they have a deep sulcus. So when you do the right at the base, I notice that my finger goes way in, right? I call that a deep sulcus. So that sacral sulci that I showed you how to do, it drops down lower towards the table. Then I go walking myself down to the ILAs. Now that ILA, what they call is more shallow or posterior. So, right-sided here, it means it's coming up towards me. It's shallow or more posterior. So, here's my sacrum. I'm like this. Deep sulcus was on the right. My ILA was a little bit higher, right? So we know it's a sacral issue, sacral dysfunction. They have a right unilateral sacral flexion. There's a whole lot of movement in the sacrum. It goes all over the place. All sorts of rotations. Number 3. Positive standing flexion test on the right. Negative seated flexion test. You have a nominate problem. Supine exam. Iliac crest are equal. ASIS is superior on the right. Medial malleolus, slightly superior on the right. That is very difficult to see with this diagnosis, I'm not going to lie. It's in there, but it's sometimes unequivocal. Prone, PSIS, inferior on the right. This sounds familiar. Ischial tuberosity is inferior on the right. Diagnosis? Did you get it right? We just did it. Was anybody else? So right, posterior, and nominate rotation. Here comes the hard one. So go through it, pull out your fingers. I'm throwing a curveball at this one for you. I wish I had some type of prize. Usually I have some type of fun prize. Here we go. Standing flexion test on the right is positive. The seated flexion test is negative. You have a nominate problem. All I care. If you walk out this door and can just tell me that, I'm good. Now, my supine exam. Your iliac crest is superior on the right. Okay? So it's superior on the right. So, again, I use my thumb as my iliac crest, so I put that a little bit higher. My ASIS are equal. Medial malleoli, it's inconclusive, really. I can't figure out if they're equal, if one's slightly higher than the other. It's not really telling me a whole lot. So then I go prone. My PSIS is superior on the right. Okay? And my ischial tuberosity is superior on the right. Okay? Pubic symphysis with this one is slightly superior on the right. Anybody? Told you it was a curveball. What are the first things that come out at you? So you already said that my iliac crest is superior on the right? And medial pubic symphysis is slightly superior on the right. You're thinking what so far? Wait, so who said? Who just said that? Say it loud and proud. Go for it. You got it. 100%. You have 2 diagnoses here. You need it. See? I got to get you a prize for that. That was awesome. Good job. What they had is a right superior shear, right? So you're here. My iliac crest was higher, right? My pubic symphysis was slightly higher, but what happened? My ASIS were equal. So I rotated forward as well to make these bad boys equal. That wasn't very nice, but it's a good one. I see it as well. So it was a little bit more difficult. Did everybody understand that one? So use your fingers to help you to try to figure out what is going on, right? Because it can be a dual thing. So, guys, I cannot thank you all enough. All the time. I like to do this again in the smaller groups so we can all test it out and do things. I hope this way y'all can at least walk out of here and tell me, if you call me on the phone and say, Dr. Stevens, hey, I got this. Patient had an innominate problem. I fixed it. It's been fine. We're good. Awesome. That's what I want to hear.